This is my fight song. Take back my life song. Prove I'm alright song. My power's turned on. Starting right now. I'll be strong. I'll play my fight song. And I don't really care.
Hello folks, welcome back, and this is probably the final of the 5 series of videos that we're doing for the Thomas Jefferson EMS Council's 2017 Medical Guidelines rollout. And this afternoon we have Dr. George Lindbeck with us, who is the State Medical Director and also the Medical Director for the Thomas Jefferson EMS Council. And he's going to have a go and go through these medical guidelines. There are some changes, and like we said in all the others, we can't really go over the whole guidelines, so certainly read them and make yourself familiar with the changes. But we'll try and touch the big points. So welcome. Thank you.
Thank you, Tom.
So one of the things that people will see that was not in there before, lots of talk about pain management and stuff. There was never really a pain management guideline. You had to sort of hunt and peck through the different complaints. This time there is a pain management guideline. Why did we bother?
Well, Tom, what we tried to do was come up with a consistent pain management guideline that then we would reference in each of the applicable guidelines rather than having it appear multiple places and potentially conflict across different guidelines or protocols.
So in this go around, the 2017 revision, we very specifically talked about particularly fentanyl and opiate, administration. There seems to be a change within the industry to 4 or 5 years ago, I think probably based on some federal government encouragement, that pain was a big deal. And we're not saying pain isn't. If you have pain, it is a big deal to you. But there was nearly the practice where an awful lot of opiate was being given out. And in this guideline, we're asking for you to give 50 mics, a maximum of 100, so 2 doses of 50 mics, and for those agencies that are going to use this as their primary guideline, after that we're asking you to chat to somebody, to chat to a doc, if you want to give more than that. Compared to what people have been given, and you see in the charts, and when you do the chart review, that seems quite a bit less than what people are giving out. What's the reasoning to dial back on that?
Well, several years ago, we got concerned that we were not doing a good job of managing pain pre-hospital, and we did try to make that more of a priority. We added some pain control agents, particularly fentanyl, which is a synthetic opiate that has some characteristics that are good for pre-hospital care, rapid onset, fairly short duration, tends not to cause so many problems with low blood pressure. But I think that over time the pendulum might have swung a bit too far the other way. And we were seeing patients get very large doses of opiates pre-hospital, 200 micrograms plus of fentanyl over 20 and 30 minute periods of time. I don't think that sometimes the pre-hospital providers saw the sedation that caused, but we would deal with it in the emergency department. So our goal here was to try to refine our pain management a little bit more, give people an opportunity to manage pain, improve the patient's pain, but not necessarily make the pain go completely away.
So I think that's one of the things that's probably worth noting, that we give these pain meds, the analgesia, to people to make the pain they're having tolerable for them. I think if you're setting a goal of, and you correct me if I'm wrong here, but if you're setting a goal of completely eliminating any pain sensation from a bad injury, absent of putting them asleep, that's probably not what you're headed for.
I don't think that's the goal. Yeah. Correct. Right. And we're trying to avoid side effects such as sedation, particularly in some of our older patients, people who are taking other medications that might synergize with the opiates and cause excess sedation.
So you referred there a second ago to the ER having to deal with the end product of people having frequent high doses of opiates, whether it be whatever particular drug you're using. And I think there's probably an opportunity to speak about, if I, for example, just to make up a case, if I give somebody 100 of fentanyl and then 10 minutes later I give him another 100, and then we're an hour of a transport and I give him another 50 or so. So in a 30-minute period of time, he's had 250 mics of fentanyl. Can you explain to us, as we understand better the actions of these medicines, why now, 20 minutes after he comes into the ER, you have to wake him up to talk to him, whereas he was doing fine with me?
Well, there's certainly a cumulative effect from these medications, and we can get some stacking of doses and some buildup of medication and then some cumulative side effects. And it wasn't that we were making people stop breathing or bad things like that, but we definitely noticed that they became harder to interview, harder to assess once they got to the emergency department.
Do you think, we live in an environment now where illicit or incorrect use of opiates is talked about everywhere? It's all the rage. Everybody's rightly concentrating on this as being a killer of particularly young people. Do you think that EMS worsens any of that to any degree if we're, so to speak, freely giving out opiates to people? Do you think we have a part to play in that problem?
I think that the opioid epidemic, if you will, is real. I think it's a very serious problem. However, I think that reasonable, wise doses of opiates given to people for pain control acutely are pretty safe. It's given tens of thousands of times a day across the country with very reasonable side effect profiles. I don't think that pre-hospital pain control is either starting or fueling the opioid epidemic. We're more concerned about acute side effects that we're seeing in these patients from oversedation. Are there very occasional patients who use the EMS system or the 911 system incorrectly and are seeking opiates? That happens. I think it's a small slice of the pie, but I think our systems and our providers need to be aware that there are some patients who may be using our services for to make access or have access to narcotics.
So I think the thing we're trying to emphasize here is certainly pain is a real thing, and discomfort for patients is a real thing, and we should be addressing that as part of our plan to best care for these people who are sick or injured. But giving large amounts of opiates, larger isn't necessarily going to get you a better effect. So we're not saying don't give them pain medicines, but what we are saying is be judicious and be clever about how you use it, and try to adopt a best practice where giving lots and lots isn't necessarily going to get you any better benefit anyway. Would that be fairly correct?
I think that's a fair way to put it.
So one of the other things that you're going to see here, and it's been in here quite a while, but I think there's been some discussion, certainly in the Medical Control Committee for the Council here, is the use of ketamine, not necessarily as a primary pain agent, but as an adjunct to the existing medicines that we are using. And for any of you who keep animals, and I know Dr. Lindbeck and I keep some horses, ketamine is an old favorite. It's been around in animal practice forever and ever, but seems to having some sort of resurgence in the human population. We're putting in here 0.5 milligrams, a half a milligram of ketamine per kilo. Where do you see that, Dr. Lindbeck, in actual practice? I've given, we'll say, for example, maybe I've chosen to go with the 2 doses of 50 or 1 dose of 50 of fentanyl. Where do you see me using the ketamine at that point? Do you think I could give the initial 50 of fentanyl with a little ketamine, or to be used as separate agents, or to only be used the ketamine as when I'm not really getting anywhere with my fentanyl? How do you think that would work?
So I would resist the temptation to give them both at once. I think you should pick an agent and then go to the maximum dose of that agent before you move on to a second drug. Ketamine is very useful medication. It's used in a variety of circumstances. We initially looked at a dose of half a milligram per kilogram up to a dose of 50. But what we found was that patients, although they were getting pain relief, were having unpleasant dissociative symptoms from the ketamine, basically a bad trip from the ketamine. And we actually had patients come back to agencies and complain or note that they did not like that experience. It was very unpleasant. So based on some experience in civilian EMS as well as the military, we've decreased that dose to a single 20 milligram maximum dose, which seems to work quite well in terms of pain relief. There are some situations where ketamine is used at higher dosages, 1 to 2 milligrams per kilogram IV, or even 2 to 4 milligrams per kilogram intramuscularly as a sedative drug or as an induction drug for RSI, and that's not what we're looking at here in our protocols. There are some patients, I think, and we've specifically talked about patients with burns or patients with isolated mangled extremity injuries, where going to ketamine initially might be a reasonable step. So as you pointed out earlier, you've got some different tools in the toolbox. You need to make some informed choices about what you go to first. In many cases, I think that fentanyl would be the good drug to start with, and then move on to ketamine if you don't find you're getting adequate effect.
So it's probably worth noting here, and I forgot to mention it earlier on, that the dosing we have in these guidelines is that 0.5 per kilo up to 20 for an individual dose, with a maximum of 40 for all doses. So we should probably know that we're not giving 40 as, you know, one dose. And even at the kilogram weight, when you work that out, it's 20 for a maximum single dose and 40 for total dosing. So now that we've addressed the pain control issue, and as we've said now, you have a specific guideline where you don't have to hunt and peck around the guidelines looking for what the pain control medications are, we probably move on to seizures, is something that a lot of people talk about. And one of the things you'll see in the guideline is every flavor of seizure was written into that guideline at one point, and we've tried to make it this time around to take out as much of the fluff as we can and put in things really that we're dealing with day to day, not the abstract things that you might see once in a long time. So you'll see in the guideline that we're really talking about full body generalized seizures, and we've removed the reference to all the other many different types of seizures. So chatting about seizures, a lot of people seem to have a divergent opinion on whether or not isolated seizures in a person who's known to have a seizure disorder is something that we previously, you know, we didn't want anybody seizing at any time, and we were on it and we gave multiple doses of medicine to them, and that, you know, Valium at that time. How worried are you about the person who's known to have seizure disorder and has, so to speak, a breakthrough seizure, as opposed to somebody who has a seizure, a first-time seizure, or a seizure from getting hurt, a traumatic event, leaving them out, people with known seizure disorder?
One of my rules is that people who have seizures have seizures. So not to minimize them, but some patients don't have very good control of their seizures, and they do have breakthrough seizures. And just the fact that they've had a seizure that is self-limited and already terminated may not be that much of an emergency, and therefore may not need us to intervene. The patient that is still seizing when an EMS unit gets on scene, so either has had recurrent seizures or has been in seizure ever since the 911 call was made, though, I think is a different situation. And in those cases, we would like to terminate their seizure. As you indicated, for many years, the drug we had in the drug boxes was Valium. Valium definitely works. Problems are that it required an IV. It could be given rectally, but was very seldom administered that way. Valium is not recommended for intramuscular administration. Many would like to use lorazepam or Ativan as a seizure medicine. Our major problem with the drug kits was that it requires refrigeration. And pharmacies were unwilling, or reluctant, I should say, to stock it in unrefrigerated drug boxes that were stored in units. A few years ago, a study came along, the Rampart trial, or rapid administration of midazolam, Versed, prior to arrival, which showed that IM Versed was equally efficacious or equally effective as IV midazolam or Ativan. The benefit there is it can be given very rapidly without needing an IV. So our mindset really switched, and if units get on scene and somebody is still seizing or has had recurrent seizures, then we can treat them quite quickly with an IM dose of Versed, then move on to placing an IV and think about subsequent doses of medication if needed.
So really, in practical terms here, if you think of a regular EMS call, no matter busy agency or large or small agency, this quite a period of time as regards if you're seizing has gone by the time they call 911 and you show up. So if you're still seizing, we're encouraging people to give the IM dose, which is 10 milligrams, right up front, and then go about doing the other things you do. You may get your IV access at that point, or your vascular access, is where we've changed that nomenclature in the guideline. And then a discussion with somebody with online medical control. We'd really like to see you do the first dose, and prior to giving the second one, have a discussion with somebody. But then at that point, that may be when you have done your IV or your vascular access and you're giving the second dose, which would not be 10, would be 5 milligrams if you were giving it IV. So just sort of finishing off, there are a few little bits and pieces put in the poisoning, overdose, toxicity, that generalized guideline. And one of the things we're talking a little bit about is reversal of opiate medications. And we have tried to encourage people where the original dose for many, many years was 0.8 milligrams as an initial first dose, encouraging people to maybe use 0.4. And in the IV setting, obviously we have the intranasal Narcan now. Do you have any feeling on whether it's really necessary to wake an opiate overdose up to where he's chatting and talking to you? Is that really medically necessary? What is the benchmark that you're looking for as regards reversal? Up to what point?
So I think that Narcan or naloxone can be used with some finesse. Patients who have overdosed and are habituated to narcotics, opiates, I should be more specific, if you give them a large dose of Narcan, it's effective and frequently memorable because they are going to go into acute opiate withdrawal, which is going to be unpleasant for everyone involved. The way that opiates hurt people and can cause death is through respiratory depression. So our goal is really to keep them breathing. If they are intoxicated but still breathing adequately, adequate SATs, maybe adequate end-tidal CO2 levels, we really don't need to reverse that patient in the field. As others have said before, a sleepy overdose can be a good overdose because they are much more easily managed than somebody who is awake, maybe combative, acutely uncomfortable. You get the idea. And then we can give smaller doses of naloxone or Narcan, just enough to keep them breathing without needing assisted ventilations, but not aiming to completely reverse the opiates.
I think that's kind of an often missed point. I mean, one of the things we do, we would hope that these patients are to some degree better off from having met us than they were beforehand. And I think it's probably worth giving a little consideration to yourself in your own practice to reverse a person completely who is, as Dr. Lindbeck said, a habitual user of opiates. I think it wouldn't be unreasonable to say is really kind of cruel. The syndrome that they experience all at one time, that withdrawal, is very unpleasant, very painful. And if we can do what our goal was to prevent them from dying from their overdose, and we can do it in a gentler way, I don't think it's unreasonable to do it the nicer, kinder way, would you think?
I think that's a reasonable way to look at it.
So, wrapping it up, the end of this series of 5 videos, I'd like to thank Dr. Lindbeck for coming in, and all the folks who came in. A lot of them came in early in the morning, having worked night shifts beforehand as we did these. The usual people I'd like to thank, obviously Hoopla Media did this with us, and a special thanks again to Lifecare Medical Transports, who provided the finance to do this that we would not otherwise have been able to do it. Have a look at these. There were things that people had said they wanted to see an explanation rather than just see something in writing or on a cell phone app. If this is popular, let us know at the council and we'll do it again the next time. If not, it's a learning experience. So thank you all indeed. Bye.